بسم الله الرحمن الرحيم. قالوا لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. صدق الله العظيم. Session today, basic ECG part 2, ischemia MI, miscellaneous, by Dr. Amr Abu Zaid. As mentioned in the previous session, خلاص the ECG, for ECG algorithm, AV block and arrhythmia was taught in last time. And we start today with the atrial enlargement and then bundle branch block, ventricular enlargement, these three items with each other, and then ischemia with MI, and then miscellaneous, including axis low voltage, hyperkalemia, electrolytes, hemiblock, WBW, and others. Atrial enlargement, first, regarding the arrhythmia, and the AV block, we was looking mainly, okay, in the AV block lead 2 only, long strip lead 2. Okay, regarding arrhythmia, we are looking for first lead 2 and AVR to see if it's sinus or not. Okay, and then in the long strip. Okay, see if there is P. And these P's all are the same shape or not, and then if they all are the same shape, it is sinus in shape or not, or the same direction. Okay, and then if they are, if not, there is no P, junctional, or as we said before, junctional or AF. If it's regular, so junctional. If irregular, so AF. And then if it's wide and bizarre in shape and the T in the other direction of the QRS, so it is ventricle. Regarding atrial enlargement, we will look for lead 2 and V1. Okay. Left atrial, we have left atrial enlargement and right atrial enlargement. Left atrial enlargement, if we have left atrial enlargement, it's called P mitral. The normal of P wave is 2.5 in amplitude by 3 millimeter, okay, in the time. Okay, so if it's more than 3 in width, so it will be left atrial enlargement, 3 or more. This is in lead 2. Plus or minus notch. Notch is not a must. Okay, so if there is notch, it's okay, will be M shape. If there is not, if there is isn't notch, will be also left atrial enlargement, but without notch. Okay, so notch is optional. Okay, not mandatory. Here in V1, the normal that P wave is either negative or biphasic. Okay, in left atrial enlargement will be a negative deflection here, more than 1 in 1 millimeter. Okay. For left atrial enlargement, we need only one criteria. That's enough. So if here the left the P wave width more than 3, and here normal negative deflection, or biphasic, so there is left atrial enlargement. Or here this one and here normal, so it's also left atrial enlargement. So we only need one criteria. Clear? Regarding the right atrial enlargement, the same leads, lead 2 and V1. Okay? Here, the difference will be in the amplitude. Okay, the height will be more than 2.5. The normal is 2.5 by 2.5 or maximum 3 in width. The height, maximum 2.5, more than 2.5 will called P pulmonale, because mainly increased with any side, any right-sided increased pressure, such as pulmonary hypertension, okay, chronically, pulmonary stenosis, and others. This is one sign. The other sign in the ECG in V1 also. that the positive deflection is also more than 1.5. So 2.5, 1.5. Okay? One sign also enough. Biatrial enlargement. Patient with MS, left atrial enlargement, pulmonary hypertension, right atrial enlargement. Okay? So one sign from each is enough. Here, for example, we have many options. This P wave in width more than 3 and have
height more than
2.5. So this is alone. If this is normal was normal, this is alone biatrial enlargement. Okay? And here, the height of the positive deflection more than 1.5 and the negative deflection more than 1 by 1. So this is alone biatrial enlargement. Another option, we can see here only P mitral wide and here only P pulmonale long with normal negative deflection. So left here and right here will be biatrial. Okay? Or right here, left here, biatrial. Or in one lead, both biatrial. Okay? So one sign is enough to diagnose atrial enlargement. The cause of atrial enlargement, left atrial enlargement, MS, most common cause, MR, mitral regurg, LV failure, okay, especially the diastolic dysfunction, and left or right shunt. Regarding the right atrial side, right atrial enlargement, TS, tricuspid stenosis, okay, and then TR, RVF, okay, PS, ASCD, pulmonary hypertension. This was regarding the English. The second thing will be the bundle. Okay, so left atrial bundle, atrial enlargement, bundle, ventricular enlargement. First of all, before we looking for any bundle branch block or comment on it, the first thing, the QRS complex should be more than 120. If not more than 120, don't comment. So we'll skip this step. Okay? Clear? The second thing, where will we look? We will look in V1 and V2 and V5 and V6. Regarding the right bundle branch block will be one of in the V1 one of two patterns. R dash. R is the first positive, S the negative after positive, and R dash is the second positive. Okay? S means that this is a negative deflection below the isoelectric line. Okay? If this is negative deflection, if there is a negative deflection but not below the isoelectric line, so there is no S. So it will be R dash. So this is R dash, not there is no S. There is no delta? No. This is R wave positive, then there is a negative deflection, and R dash, and this complex is Y. Okay? So this RS R dash, this R dash. Very, very important to notice that there is a secondary T wave inversion. So if you have right bundle, you can't, okay, diagnose ischemia, okay, septal ischemia. Clear? And if you diagnose septal ischemia, so you are over-diagnosing, okay? Because this is secondary to the right bundle, not related to ischemia. Clear? And why the algorithm? Okay, why we are following the algorithm, not to over-diagnose. So ischemia, we not comment on ischemia till now. Why? Because we should exclude first right bundle. Because if we commented on ischemia here and we neglected that there is a right bundle, so this is a wrong diagnosis. This is over-diagnosis. Okay? What will you see in V6, V5 and 6? V6 will you see QRS with slurred S. This slurred S It's delayed in upslope. Okay? So in right bundle, don't diagnose myocardial ischemia and ventricular enlargement. Right ventricular enlargement. Why? Right ventricular enlargement, as we will take, will show a long R in V1. Okay, so this long R in V1, okay, caused by bundle branch block, and you can diagnose right ventricular enlargement.
حتى لو كان لسه ديبريشن مثلا في ليد 2 مثلا.
No.
يعني مثلا
I'm talking about V2. Yes, you can.
Okay.
Okay, but in the inferior you can. It will not affect here. Okay. We are talking about here mainly, especially the lateral you can, and maybe inferior. But in the anterior leads you can't. ST elevation you can, but ischemia you can judge. Okay.
حتى لو في ST depression.
Yes, you can judge. Regarding the left bundle, the left bundle also you will look for the same leads, V12, V56. What will be the pattern? This pattern either QS or RS. Okay. Why the name QS, not Q? To differentiate it by name from the pathological Q. Because pathological Q, it looks like pathological Q, but it's not caused by ischemia. Okay. So named QS. Or secondary, the J point there may be ST elevation here. Okay. So you can't follow the same criteria for ST elevation. Okay. There is special criteria for ST elevation with all the left bundle. If the patient was sinus rhythm and there is no ST changes and become another complex, become new left bundle, it's considered as ST elevation MR and go with the same algorithm of management. Okay? But if the patient has all left bundle and has chest pain, okay, typical ischemic chest pain, you can't judge for the ST here. There is a special criteria we'll take it called Scarbose criteria, okay, to know if this is a new ST elevation or not. Here in V6 will be monophasic R plus or minus notch. So it's not a must to be M-shaped or rabbit ear. Okay? So maybe monophasic R, and there is a secondary T-wave inversion. Okay? So in left bundle, you can't diagnose myocardial ischemia, especially in the lateral leads, okay, and ventricular enlargement, okay, the same, because the ventricular enlargement will depend on the length of what? Of the R in V5 and 6 and the S in V1 and 2, okay? And myocardial infarction it can be diagnosed if new onset left bundle or by a specific criteria, Scarposa, and we will take it. And also the hemiblock. Clear? So this is the secondary T-wave inversion and the left bundle. So the notch here, what are the left leads? V5-6 or V1-2? 5-6 are the left leads. So in the left bundle, the notch will be in the left leads. And the right bundle, the notch will be in the right leads. Okay? Just to memorize. If the QR is normally it's less than 100 milliseconds, okay, between 100 and 120. If it's more than 120, it's bundle branch block, either left or right. If less than 100, it's normal. If between 100 and 120, it will be
partial.
not partial, intraventricular conduction delay. Okay? So white QRS pattern not consistent with right bundle refund, it's between 2.5 and 3, will be intraventricular conduction delay, and the cause will be myopathy and hyperkalemia. Okay, let's continue. We'll take the scarbosa with the MI. Okay. So now we finished the area enlargement. We will look for V1 and lead 2 and V1 and both atria. And one sign is enough. And we finish the bundle branch block. And first we should look for the duration, and the width will, of the QRS complex should be to diagnose should be more than 120 millisecond, which equal to 3 small squares. The third item will be ventricular enlargement. The ventricular enlargement, the same leads as the bundle branch block, V1 and 2, V5 and 6. We have many criteria. We can take one and bend on it, okay? 1 or 2.
7 big squares.
Yes. First criteria for the left ventricular enlargement, okay, will be, we will look for the R wave in V5 and or 6, which is taller, okay? If it's taller in V5, will depend on it. If taller in V6, will depend on it. The taller R in V5 or V6 should be more than 5 big squares or 25 milliseconds, okay? Or the sum of the height of R and the depth of S in V1 or 2, which is deeper, okay, should be more than 7 squares, okay, or 35 milliseconds, okay. The other criteria will be the R in AVL more than 12, okay. If you didn't find both, this is the most popular, okay. You can judge by the AVL if more than 12 millimeter, okay, or more than 12 small squares, so the patient has LVH, okay. But the patient shouldn't have left bundle branch block. So you should exclude first left bundle, okay. There is a very important note here that there is also a second wave inversion here, what we call strain pattern. Strain pattern, we will find it in V5, 6, and maybe in 1 and veil, in the lateral leads. Those are low lateral and those are high lateral. So you can't diagnose ischemia in the lateral leads with LVH. So why we take LVH and comment on it before ischemia. اوكي.
طب هو في الالفيش دايما انت عندك ثيكنينج مايوكارديوم وعندك secondary ischemia الثيكنينج على المايوكارديوم صح؟
Strain pattern, not ischemia. This is not ischemia. Strain from the straining from the pressure overload over the LV wall. Okay. Clear? Right ventricular enlargement. The right ventricular enlargement is the same as the left ventricular and the bundle branch block in the same leads V1, V2, V5, V6. Okay? What are our criteria for diagnosis? First, tall R in V1. Tall R in V1 first should be narrow complex to exclude right bundle, and then tall R in V1. The tall R in V1 will be more than 7 millimeter or 7 small squares, okay? If the patient has low voltage or for any reason the R is not more than 7 small squares, we can depend on another criteria which is the RS ratio. That the R is longer than the S. The height of the R is more than the depth of the S. Okay? That's enough. Clear? So, If it's more than 7, even the S it's deep, so it is L the RVH. But if it is less than 7, it should be taller than the tips of the S. The same thing, there is a secondary T-wave inversion from RV strain, okay, and we will see in V1 and V2. What will you find in V6? You will find in V6 deep S, okay. Practically only will depend in this, okay. Here there is a very important point should be mentioned. What's this point? The posterior infarction. The posterior infarction will mimic the RVH. One of the causes of tall R, normally V1 is either Q, okay, without, not pathological Q, or with a small r. This is normal because the axis, okay, the electricity go away from the V1 on the right ventricle, and the axis of the heart towards the left ventricle. Okay, so the electricity go away from the V1, so will be either negative or very small r. What there are many etiologies of tall r in V1. As we taken before, what? Right bundle. Okay. The second here, RVH. The third, posterior infarction. Why posterior infarction? If you see like this, okay, V1 and V2 and V3 will be the mirror of V7, 8 and 9. Okay, the posterior. So posterior infarction diagnosed by tall R in V1 with ST depression V1, 2, 3 with ST depression in V1, 2, 3, okay, and the only difference is the T. The T here in the RVH is inverted. The T in the posterior infarction will be upright as the evolving MI. Okay, so we will flip it, will be clear. The other signs with the RVH will be right axis deviation, with LVH will be left axis deviation. Was the same with the left bundle or right bundle. Pacemaker pattern. This is a pacemaker pattern of a temporary pacemaker or permanent. Wait a moment. This is a pacemaker pattern. Okay, we have regarding the pacemaker. This pacemaker lead in the right ventricle. How we know that is the right ventricle? Because once it's the right ventricle, what the pattern will it give? Left bundle morphology or right left bundle branch block morphology or right bundle branch block morphology? What's the pattern of the ECG for the if the temporary pacemaker or permanent pacemaker the lead in the inserted implanted the lead in the right ventricle? No, in the right ventricle. So which ventricle will be activated first? The lead in the right ventricle will be activated first, and then the left ventricle will be activated later. Okay, so we'll give a left bundle morphology pattern, because during the left bundle branch block, the right bundle first through the electrical pathway activated, and then the left ventricle activated through the myocardium. Okay, later. Okay, so gives the left bundle morphology pattern. Okay, so this is how we know that is a pacemaker pattern from this spike. This spike from the generator. Okay, this means that this is spike before the QRS, just before the QRS spike, and this is in the right ventricle, and either temporary or VVI. Okay. We have mainly three for the nomenclature of the pacemaker. We have three letters. First letter for the pacing, which the pacing from which chamber. Okay, either atrium or ventricle. So if it is V, so from ventricle, ventricular pacing. If it's A, so it is atrial pacing. So if it is, you will take the video.
Oh no.
If it is D, so dual pacing, atrial and ventricular. Clear? The second will be the sensing. What means sensing? That the pacemaker will sense if there is any intrinsic activity. Is the own rhythm of the patient. Okay, so if the sensing from the ventricle, so it will be V. From the atrium will be A. From both will be D. The third will be the third letter will be the action, either inhibitory or stimulatory or dual. Okay, so will be I inhibitory and dual will be D. So we have DDD, this means dual pacing, dual sensing, dual action. Okay, VVI, ventricular pacing, ventricular sensing, inhibitory action. When the pacemaker senses that the patient has an impulse in the ventricle conducted from the atrium, okay, so will inhibit itself and make the patient depend on its rhythm, will not, okay, will not interfere. AAI, atrial pacing, atrial sensing, inhibitory action. Okay, there is a fourth letter, R. R is rate adapting or rate dependent. This mainly for the active patient, young patient, okay, because, so once he make more exertion, more exercise, so the rate will increase, will not be a fixed rate, okay. If there is a problem in the SCA node, so and the AV conduction is completely normal, okay, so we will need which mode?
Again?
The problem in SCA node, 6 sinus syndrome. The SCA node sometimes go to sinus pause, sinus tachy, sinus brady, okay,
Atrium.
sinus arrest.
Right atrium.
Yes, atrial. So we need atrial. So we will not need a ventricular lead at all because the ventricular conduction is completely normal.
Yes.
So we'll need AAI or AAIR. Okay?
هل نحتاج سنسور طول الوقت؟ يعني
Yes, one lead in the right atrium and the mode AAIR.
إذا كان مثلا الاس اي نود ما هي شغالة أبدا مثلا خالص.
Yes,
AAI.
AAI.
سنسور مثلا. Why do we need the sensor مثلا إذا ما هي شغالة؟
The sensing in the same lead, in the same lead. Okay? So we need AAI. What will make the AAI? Will make atrial pacing. If there is no activity, the pacemaker will sense first if there is no there is activity, will inhibit itself and will not interfere, and if there is no activity, there will be atrial pacing, and we'll go directly through the AV node, conductive pathway, and will be narrow QRS complex through the conductive pathway and nothing else. Okay, and there will be a spike before the A wave only, not before the B, before the QRS. Clear? Not mentioned here, not like this or this, only before the A wave. Regarding the spike, there is a small spike and there is a large spike. almost in the permanent pacemaker will be very small spike and you may not don't notice it. Okay? You may not notice it. Why? Because it's bipolar. The two poles are in the tip of the lead, and so make a very small spike.
So you
In
can
the
see
temple,
it in the monitor, it appears
you,
in the monitor.
for permanent, you may not see it. For the temporary, you will see it as the patient in 44. Okay, you will see it. There is because it's unipolar. Okay, so unipolar will give you a large spike. Okay, and the old devices. Okay, all the permanent devices. But now all permanent bipolar and very small spike, and you don't notice it. Okay. Regarding the so if the patient has AV block, complete heart block or morbid stroke. Regarding the first AR, patient has six sinus. If the patient complain of syncope and have you make halter for him, and you notice that there is an sinus pause. What I mean by sinus pause? There is a pause. QRST, PQRST, followed by pause. There is no P. What's the indication after the pause to how long will be the pause to put pacemaker?
3 seconds.
3 seconds. So if the, we'll make halter, if this pause is 3 seconds, the patient indicated for permanent pacemaker. Okay. 3 seconds equal how many small square? One big square?
5.
15? Okay, 1 second, 5. Okay. Okay. Regarding if the patient has complete heart block, AV nodal dysfunction. Okay. So what will be the mood for him? Old patient, 90 years old, limited mobility. Okay. Which mood will be for him?
PV.
VVI. Yes. Okay. There is atrial activity, normal atrial activity. It's a problem in the AV conduction. Okay. So it will be VVI. This lead, one lead in the right ventricle will sense if if there is any atrial activity pass through the AV node to the ventricle. If there is no atrial activity, it will pace. Okay. If there is atrial activity pass, so it will inhibit itself. Clear? If there is a young patient, 40 years old, and well function, okay, and complaining of complete heart block. What suffering from complete heart block? What's the mood?
Dual.
Maybe dual, maybe according to the finance. Okay. Okay. If there is a problem in the finance, maybe go for
RCT.
V V I R. Okay. If there is no problem in the finance, R for the rate response. Okay. If there is no problem in the finance, will be D D D R. Okay. Dual pacing, dual sensing, dual action, rate response.
Oh, CRT, 3
No,
leads.
CRT is 3 leads, including a lead in the left ventricle to synchronize both right and left ventricle. But the pacemaker is either lead in the right ventricle or right atrium or both. Okay. The advantage of the dual that it will preserve the atrial kick, the synchronization between the atrium and the ventricle if the patient complained from pacemaker syndrome. What's the pacemaker syndrome? Pacemaker syndrome that there is in the BVI there is evolution. Yes. During the BVI, if there is atrial activity during the ventricular, nothing, there is atrial activity, P wave, activated the both atria, okay, and there is atrial activity for atrial conduction, for atrial contraction, okay, and nothing passed through the AV node to the ventricle, okay. So the VVI will pacemaker will sense nothing but so it will pace. Okay, so the ventricle will contract. If it is contracted both simultaneously at the same time, this is a pacemaker syndrome. There will be a giant A wave, okay, and this is the pacemaker syndrome. For this to be synchronized and to prevent pacemaker syndrome, DDDR will be better for you, okay?
ثلاثة